To thank Dr. Arun Kesos for giving me this opportunity to talk about survival in neuroophthalmology. So I've been asked to talk about the basic signs and symptoms in neuroophthalmology, which a general ophthalmologist should not miss. The usual symptoms in neuroophthalmology that the patient presents with are sudden vision loss, double vision, drooping of eyelids, involuntary ocular or facial movements, pain on combing or chewing, sudden or a new kind of headache, unilateral glare, at times tinnitus, epistaxis with ocular signs and symptoms, at times neurological, sensory or motor weakness with ocular signs and symptoms. Now, out of these, it's very unlikely that somebody will miss the diagnosis when the patient is presenting with sudden vision loss, double vision, drooping of eyelids, involuntary ocular facial movements. Usually, everybody is able to diagnose. Some amount of diagnosis is possible. But with the last 5, you can easily miss the diagnosis. So a detailed history taking and evaluation as well as investigation for the last 5 are important. Now we are going to look at each of these symptoms and combine them with different signs. Now a sudden vision loss can present with all of these. Patient can present with sudden vision loss with a normal fundus, unilateral disc edema, bilateral disc edema, unilateral or bilateral neuroretinitis or optic atrophy. Out of this, if the patient has presented with unilateral or bilateral disc edema or neuroretinitis, you can see, you know that the patient has an inflamed optic nerve or something is happening in the optic nerve. It's very important that you refer the patient to a neuroophthalmologist as soon as possible because the time lost is neuron lost. Or if you're sure, treat it. In case of an elderly patient, do an ESR or CRP immediately to rule out a GCA. Now we look at cases. Now somebody presenting with normal fundus in one eye, normal fundus in both the eyes with unilateral vision loss. Now, how to go about this? In such a situation, looking at the pupils is very important. Now, right pupil was sluggish, left is reacting. So we're going to elicit RATV. Patient has a normal fundus and complaining of decreased vision, right eye. This is dilating, left is constricting, right is dilating, left is constricting. So the patient has a relative apparent pupillary defect in the right side. Fundus was normal. Patient has something going on in the optic nerve on the right side. I confirmed the diagnosis by doing a VEP. And the VEP is indeed showing delayed latency with reduced amplitude. I confirm by doing an MRI and it shows optic neuritis on the right side. Now, when the patient presents with bilateral vision loss with normal fundus, the vision loss could be equal. The affliction of the optic nerves could be equal on both the sides. So relative apparent pupillary defect may not be there. So you do a visual fields. And it gives a lot of information. In this particular case, the patient has a bitemporal hemianopia because of chiasmal compression. You can see the chiasm getting compressed by this mass lesion, which is a pituitary adenoma. So the take-home message is always do a visual field examination in case of unexplained vision loss. Let's look at some cases of bilateral disc edema. Now, this middle-aged lady is presented with a swollen disc. Obviously, the margins are blurred. The vessels are getting obscured. There is exudation at the disc. There is dilatation of the capillaries at the surface. So the patient has true papilledema. Patient had fulminant IIH. Let's look at another case. Again, the discs are swollen. The margins are blurred. But look at the vessels. Vessels are tortuous. And there is a hemorrhage here. There are watermark signs, there are island striae. So we are looking at an elevated disc with fuzzy margins, basically. It's a case of chronic papilledema. So be it acute or chronic papilledema, patient presents like this, we have to do MRI of the brain and orbit. If the patient has IIH, you'll typically see this denting of the posterior lobe at the level of optic nerve. Do order MR venogram if you are suspecting IIH. Let's look at another case of swollen disc. This is also pretty much elevated with fuzzy margins, palish disc. Look at the blood vessels, they're straight, there's no tortuosity. It's a lumpy, bumpy disc, and with the drusen evident on the surface. There's in fact the peripapillary CNV mode. So we are looking at a case of optic nerve head drusens. In such a case, you don't need an MRI. You can do an ultrasound. You can do CT scan to confirm the drusen. And if you have an EDISD OCT, you can directly localize the drusen. Now we are going to look at a few cases of optic atrophy. We are concerned with non-glaucomatous optic atrophy. This elderly lady, she was complaining of decreased vision for past 8 months and was getting treated as glaucoma for 4 months. She had become blind in the left eye. She had a vision of only counting fingers 50 centimeters, and IOP was normal. I don't need any other test in the eye, just an MRI, and there is an olfactory groove meningioma there. Another case of bilateral optic atrophy. Let's try to see what information we get from this image. These are obviously small crowded discs. There is a superior sectoral pallor. You do the visual fields. There is an inferior archway in both the eyes. I do the OCT. The superior RNFL is thin. So this is a case of non-arteritic ischemic optic neuropathy. Sometimes a patient presents with just bilateral temporal pallor. Could be because of ethambutol toxicity, that is toxic optic neuropathy, can be nutritional optic neuropathy. And you'll see that just to compare it with sectoral pallor of any ION, here its superior half is pale, here the temporal half is pale. Now let's look at the symptom of double vision. As a neuroophthalmologist, our duty is to pick up an concomitant squint. That is dangerous. So this 34-year-old lady, otherwise healthy female, has come to us with sudden onset diplopia 3 days. There is a left esotropia. And what is important is that the left eye is not going out. Alternating simple esotropia with full EOM, we are not concerned. But if there is an abduction limitation, there's a case of left sixth nerve palsy. And what did she have? She had an aneurysm of the left cavernous ICA. She was referred to an interventional radiologist, underwent coiling. Now, children usually present with esotropia. We know congenital esotropia is so common, sometimes can get decompensated. This girl presented with a headache and sudden onset esotropia. And other tests were normal. She had a left face turn, and EOM, again, there is an abduction limitation. So we need to localize the limitation of movement and finish the diagnosis of cranial nerve palsy. She had a pilocytic astrocytoma in pons. Now, coming to the diagnosed symptom of drooping of eyelids, this elderly lady has come to us with gradual onset drooping of the right eyelid, and you lift up the ptotic eyelid, and there is an isochoria with the affected pupil being larger than the other pupil. And she also had limitation of adduction, elevation, and depression. So in such a case, you have to rule out compressive lesion of the third nerve. In compressive lesion of third nerve, before lifting up the ptotic eye, make the patient look towards right and left side, up and down. Here you can see the ptosis is disappearing when the patient is looking towards the left and also while looking down. So there is a inverse Duhansen pseudo-von Graf sign, which are aberrant signs of aberrant regeneration of third nerve. When we are talking of ptosis, we have to talk about ocular myasthenia. So make the patient look down and suddenly look straight. So this is how focal slit twitch is elicited. You can also lift up the affected eye and the other eyelid comes down. That is the lid curtaining sign. Now, we should also look at the patient's face in toto. You have to look at the skin changes, associated red eye, and anomalous head posture. Red eye, when associated with neuroophthalmic signs, it indicates there is some infection which is creeping from eye to the brain. Now, let's try to pick up some signs here. Very obviously, there is herpes zoster ophthalmicus scar on the skin. There is conjunctival congestion on the right side. And there is moderate ptosis and isochoria with obvious limitation of the movements in all directions, all gazes in the right eye. So the patient had a pupil involving right, third, fourth, and sixth nerve palsy because of an enhancing soft tissue lesion on the right superior orbital fissure and cavernous sinus. Again, I said red eye with limitation of movements or other neuroophthalmic signs indicates something is happening in the brain. The patient had a dilated superior ophthalmic vein, and patient had, left side patient had CCF, keratoconus fistula. This lady is an uncontrolled diabetic, and she has again multiple cranial nerve palsies, which is progressing very fast. It is associated with conjunctival chemosis, redness, swelling. So this is a very dangerous sign. Patient had fungal granuloma in the SOF area and cavernous sinus area, and it turned out to be a case of mucormycosis. Now, there are certain benign conditions in neuroophthalmology also, like Adie's pupil. This is a mid-dilated pupil which shows vermiform movements on slit lamp examination. And if you want, in this anisocoria, the mid-dilated pupil constricts with dilute pilocarpine, as can be seen here. There's no particular treatment required for this situation, but the same cannot be said for the another pupillary abnormality, that is Horner's syndrome. I would like to share this case in detail with you. This gentleman, 46-year-old, came to me with complaints of burning sensation on the right side of face associated with decrease in vision, and there was no actual decrease in vision. Patient was 6'6", orthoporic, EOM, and all was full. And all he had was a subtle ptosis, 2 millimeter of ptosis and 2 millimeter of anisocoria with burning sensation. So he had a painful Horner syndrome. On this basis, we sent the patient for MRI, brain with head, neck, and chest, along with MRA. And the patient indeed had a distal cervical internal carotid artery focal dissection, after which the patient was sent to the interventional radiologist. Now, a few involuntary movements of the face. Here you can see there is twitching of the muscles supplied by the facial nerve. So this is a case of right hemifacial spasm. Obviously, we should image the facial nerve. We should do neuroimaging with MRI in these cases. In contrast, this lady has bilateral blepharospasm. There is involuntary contraction of the orbicularis, and it can be because of local cause. As you can see, her cornea is chronically irritated. The neuroimaging is not as important as in case of hemifacial spasm. So with that, I think this is my last case. I would just like to share, this is a case of traumatic optic neuropathy, 8 months old. He had optic atrophy. There's limitation of movement of left eye in abduction. What was important was that, most important thing was that for past 3-4 months, he was keeping this cotton plug in the nose, and he had this chronic epistaxis. So we did an MRI, and indeed there was a large pseudoaneurysm arising from the cavernous internal carotid artery, confirmed with MRA and also with DSA, and patient was successfully treated with coil embolization, which saved his life. I think this is my last slide. I will stop with that. Thank you.